Okay, so good evening, everyone. I'm Sharif Awad, consultant bariatric surgeon at EMBMI Derby and educational lead and council member and trustee on BOMSS. And it gives me really delighted to welcome our first team who are presenting from Ireland. It's Wednesday, the 9th of November, 22. We've had 117 registrations for the session tonight, and thank you very much to Novo for sponsoring the session. Before I hand over to Professor Helen Henahan, who's going to introduce our colleagues and speakers who'll be presenting tonight, just a reminder about our next educational session. So webinar 23rd of November. So that'll be Rehan Hydri from UCL, something about endoscopy and surgery and complications. That'll be brilliant. Journal Club on the 7th of December by the unit in Southampton. And then we're going to follow the immediate following week on the 14th of December with the next webinar, again, coming to us from Southampton. So a slight alteration in the dates only because of Christmas coming up. We didn't want to hold the webinar too close to Christmas. So without further ado, can I, before I hand over, introduce Sally Abbott, who's IHP co-chair and dietitian and sits on BOMSS Council. And everyone, of course, knows Roxana, who's the trainee rep on BOMSS Council, so she's co-chairing also. I'm going to go silent in the background, and I'll hand over to Helen. So welcome, Helen, and thank you very much for running the Journal Club tonight.
And no, thank you, Sharif, for the opportunity to host this Journal Club. We're really honoured to be the first team from Ireland to do so. And I might just start by giving a little bit of background about our service. It's very much a service in its infancy. The bariatric service in Ireland was established about 20 years ago now by my colleague Justin Gagan, who's a transplant and biliary surgeon here in Dublin. And he, with our consultant endocrinologist who's established the service, Donal O'Shea, advocated really hard to develop a service for people living with obesity in Ireland. It took them a long time. But over 10 or 15 years, they gathered an MDT that provided a really excellent service, but unfortunately could only do so to very few people because funding was really limited. But they've continued to advocate really hard to, with funders to secure funding, I suppose, to expand the service over the last few years. So I was appointed in 2017 as Ireland's first full-time bariatric surgeon, specifically to develop the service in Ireland. Just for some background on my training was, I had, apart from my SVUH training, 2 years fellowship in the Cleveland Clinic with Phil Shower. And then I did a fellowship with David Kerrigan in Phoenix Health in Aintree and Chester. That was 2016-17, just before getting appointed. So my appointment allowed expansion of the service. We got limited funding at the time. Sorry for a small noise in the background. Limited funding to develop the service and bring, the volume from 10 to 15 cases a year to about, at the time, 70 to 80 cases. Some context as well, our patients were on a waiting list for 7 to 8 years for surgery, having been worked up by the MDT. And we've, worked really hard to bring that down. It's still, the waiting list for surgery sits at about 5 to 6 years in Ireland. But we've made major progress in the last 2 to 3 years, particularly. Still as a very small team, a number of successes, I think, have been achieved in the last year in particular. We've published a model of care for how to develop bariatric services in Ireland, as well as other treatments for obesity. And that has outlined how we'll expand surgical services and develop our units to be able to provide 1,200 cases, surgical procedures per year. So that'll involve us developing our current centre to do about 400 cases. To do that, we've just appointed Naomi Fearon, a second bariatric surgeon who's here as well this evening, to allow us to get started with that expansion. And we'll develop 2 other centres in Ireland, one in Galway and one in Cork, in the next 3 to 4 years. Then more recently, in the last 2 weeks, Kathy Breen, our senior dietitian, has been the lead author and really spearheaded the adaptation of Obesity Canada's guidelines for people living with obesity to Ireland. It's an evidence-based set of guidelines that really has progressed our ability to care for people living with obesity. Kathy, I'd like to welcome next, or sorry, Sally's going to, I think, introduce Kathy, but Kathy again has led this project. She's taken time out over the last year to get these guidelines to publication. For us, it's a really major step forward for developing our service. It's really has been the first time that obesity has been acknowledged as a chronic disease in Ireland, which again is a really important step to enabling people to get treatment. And those guidelines as well outline how we should deliver surgical care to patients, both in the pre-operative and post-operative setting. And we're particularly grateful to BOMSS for allowing us to publish some of the guidance regarding follow-up care as part of our guidance. So I'll hand over to Sally to introduce Kathy, who's going to present the paper that has summarised the guidance for the summarise those clinical practice guidelines. Thanks, Sally.
Thanks, Helen, for the introduction, and it's a pleasure to introduce Kathy. Her reputation precedes herself. She's done an awful lot of hard work getting the first, I believe these are the first obesity guidelines in Europe over the finish line. So over to you, Kathy.
Thank you very much, Sally, and thank you to BOMSS for inviting our team to present. So yeah, I'm going to present on the summary paper this evening. As Helen has mentioned, in Ireland last year, we published a model of care for obesity, which described how services should be organised, delivered, and resourced. And you'll see from the model on the right that I suppose it draws on some of the UK model for the tiered approach, but also broader than that, the aim would be that the patients would move up and down that pathway depending on the complexity of their obesity and the existence of health complications. And even before any of our engagement with Obesity Canada for the guidelines, we had actually based some of the model of care on the Edmonton obesity staging system. But the model of care didn't provide any clinical guidance. It acknowledged the need for that. So there was a pilot funding which came from Novo Nordisk globally and was administered by Obesity Canada and EASO for 2 countries to adapt the Obesity Canada guidance. So we applied in a collaborative application between ourselves, the National Clinical Programme for Obesity within our public health system, and ICPO, which is our patient representative group, to adapt the Canadian guidelines and hopefully to support then the rollout, as Helen said, of high quality, non-stigmatizing obesity care within the model of care in Ireland. So methodology, I'm just going to briefly cover, I suppose, the methodology for the original guidelines. They were published in 2020 by Obesity Canada, but the work began in 2017 with a CIHR grant. It's a collaboration between Obesity Canada and the Canadian Association of Bariatric Physicians and Surgeons, and it involved an extensive literature review of over 500,000 articles. And then there was I suppose, both an evidence and experience-based framework, which encompassed about 80 recommendations for healthcare professionals and policymakers, which aim to improve standards and access to care for individuals living with obesity in Canada. And their methodology was very comprehensive, and you can read about it in their summary paper. McMaster University was involved in the original research questions, screening the literature, and then each article was critically appraised by at least 2 authors, and then these were graded to produce draft recommendations using the standard grading system. And then the recommendations were reviewed by an oversight committee, refined, externally reviewed, and then there was an iterative process between the authors and the oversight committee to finalize the recommendations. And as you may be aware, those recommendations and chapters are available on the Obesity Canada website, and they're living documents, so they're updated regularly. So in terms of the adaptation in Ireland, we used a methodology called ADAPT. So it's a framework that brings a systematic approach to adapting clinical practice guidelines to ensure they're relevant, generalizable, and applicable in the setting you're going to use them in our case in Ireland. We appointed a governance committee with representatives from each of the 3 organisations, but also public health, bariatric surgery, and primary care reps. And within the ADAPT framework, we used a number of tools to assess the quality currency, content, and consistency of the original guideline. We have a license agreement to adapt 18 of the chapters. And for each chapter, we appointed a lead author, and then they had an adaptation team to work on each of the chapters. And to give you a sense of the scope, we had 63 specialists involved across the 18 topics. You can see from topics like bias and epidemiology, science, through to assessment, and then lots of facets of treatment, I suppose, nutrition, activity, pharmacotherapy, surgery, and then setting specific, I suppose, around primary care and reproductive settings. And as you can see, we had a broad MDT representation across all of the chapters, including 2 people living with obesity who were co-authors on the stigma and participation chapter. In terms of the methodology for the authors, this was not an extensive literature review. We're very much building on the work from Obesity Canada. The authors were asked to consider the acceptability and applicability of the recommendations, and there was a tool within the ADAPT framework to allow them to do that in a systematic way. They considered grade A to C recommendations, and if they were considered acceptable and applicable, we asked them to remain consistent with the original wording. And if it was a grade D recommendation, that could be changed, but we asked that it would still align with the overall spirit of the CPGs, including person-first language and concepts of obesity as a chronic disease. And then we asked the authors to consider any local healthcare system nuances or organizational content in Ireland around the availability or delivery of services or expertise that they may have to make amendments for, population characteristics, and then things that we would maybe value within other healthcare systems that contrast or synergize with the existing guidelines. So to give you a sense of, I suppose, some of the adaptations that the writing teams made, they made adaptations for professional registrations and organisations within the Irish healthcare system. So CORU is our regulatory body, for example, around allied health. We made modifications to describe the model of care and ensure that the recommendations were consistent with what that said around where care would be delivered, and some additional references to psychological support around surgery. Made references to Irish research, and there are over 155 unique pieces of Irish research in the obesity arena referred to, but to make some modifications for the EMA around regulations that would apply to pharmacotherapy in Ireland or Europe as opposed to in Canada. Had to ensure they were consistent with existing Irish guidelines. For example, our Food Safety Authority have guidelines around sarcopenia in older adults, so not to conflict with those. We incorporated guidelines that are commonly used in Ireland, such as NICE and BOMSS, and many thanks to BOMSS and Mary O'Kane in particular for allowing us to incorporate the post-op nutrition guidelines. And we made some language updates as well. So in terms of results, I suppose two results, one being the summary paper, which you've read for the Journal Club tonight, that outlines the project and the 80 adapted recommendations. But each of those recommendations is then supported by a chapter on our website. So you can log on to asoi.info and find the supporting information for each of those recommendations. In summary, I suppose the aim of the guidelines is to shift the focus towards improving health outcomes, functional outcomes, and participation rather than weight loss alone. The recommendations are for care that I suppose is underpinned by chronic disease management principles, validates lived experiences, moves beyond simplistic approaches of eat less, move more, and addresses the root drivers of obesity. And we also use the opportunity in the summary paper to call for adequate resourcing and implementation of the model of care, and also to address health inequalities. We've called for the inclusion of obesity in our chronic disease management programs in Ireland and reimbursement for pharmacotherapy. And the guidelines will recommend these 5 steps as an approach to both how we approach obesity globally and in consultations, recognizing obesity as a chronic disease and asking for permission to discuss weight, undertaking a clinical assessment as we would for any other disease, advising on treatment, and the chapters, I suppose, cover behavioural interventions, including nutrition and activity, psychological interventions, pharmacotherapy, and surgery, and then agreeing a treatment plan and assisting with barriers, drivers, and advocacy. So in the interest of time, I'm not going to go through the 80 recommendations. So I've picked out just the recommendations, I suppose, that are pertinent to the 3 surgical chapters that would be of most interest, I think, to the audience tonight. So a recommendation, 3 of the recommendations that relate to the first chapter, chapter 12, which is around pre-operative workup and selection. And I've highlighted in bold any changes that we made to the recommendations. So you can see for the first recommendation, we're still recommending a comprehensive workup before bariatric surgery, but we felt it was appropriate to add psychological and functional evaluation to medical and nutritional. Still recommending pre-op smoking cessation and screening for obstructive sleep apnea in people seeking bariatric surgery. And if you'd like to read more about the pre-op chapter that was led by Dr. Jean O'Connell, who's an endocrinologist within our own service, we also had input from Justin Gagan, John Garvey, Claire and Farah. And you can find that on the website, as I said, with more information. In relation to the middle surgical chapter, which covers surgical options and outcomes, or chapter 13, the first recommendation is recommending surgery in individuals with a BMI of greater than 40 or 35 with adiposity-related disease. And it covers, I suppose, the indications for that and the health outcomes. The modification we made there was acknowledging that there can be improvement, not just remission, in adiposity-related diseases following surgery. Recommendations 47 and 48, I suppose, are looking at more complex obesity and indications for surgery in lower BMIs. And we just made some wording changes there, removing terms like poorly controlled and maybe using more up-to-date language there. The next recommendations recommend, as expected, that the decision around surgery is made in collaboration with the team and that banding isn't recommended. And an update to that recommendation. So there was an additional recommendation in this chapter from Obesity Canada around not recommending OAGB, and we removed that in line with current IFSO guidance. And our authors on that chapter, who you've met already tonight, Professor Helen Hennigan and Naomi Fern, also Justin Gagan, Karina Soar, and Abigail. So we had also input from our bariatric anaesthetists in this chapter, which was really helpful. And again, you can find the chapter at our website. And finally, our third surgical chapter, which is post-op management, and that's chapter 14. So the first recommendation, I suppose, is looking at recommending that surgery is undertaken in a specialist centre with appropriate expertise. So we've given guidance for where that is within our model of care at level 4. The Canadian guidance didn't really give any guidance around discharge to other levels of care because they actually don't have a model of care in Canada. So we've adapted the current NICE and BOMSS guidance around considering, I suppose, discharge to other levels of service at about 2 years. The next 2 recommendations then, I suppose, just look at what's considered appropriate care when we are discharging. So a plan being communicated and what biochemistry and vitamin and mineral supplements would be recommended if people are being discharged from level 4. The fourth recommendation looks at indications for referral back to a more specialist centre if people have complications that require that. And the fifth recommendation is again just recommending that I suppose care is delivered as per the model of care until discharge is deemed appropriate. And our authors on that chapter are Amanda Reinhardt, Chris Collins and Connor Woods. And many thanks again to BOMSS for allowing us and giving us permission to adapt the nutrition guidelines from BOMSS into that chapter. So again, on the website, you'll find we have a table that I suppose incorporates both. And many thanks to Mary O'Kane. Sorry, it's not a very good photo, but Mary zoomed into our launch last week or 2 weeks ago just to congratulate us. So thank you to BOMSS on that. So in conclusion, I suppose the dissemination and implementation of these guidelines will hopefully continue to improve care, close gaps in knowledge, and foster collaboration. In terms of the project, I suppose it's shown that the adaptation was feasible and successful. It took about 18 months relative to 4 years for the original Canadian guideline. And we hope that it has served as a catalyst to build a community of scientists, clinicians, and people living with obesity who are working to improve obesity care in Ireland with our international colleagues and with BOMSS. So thank you very much.
Thank you, Kathy. Really great to actually have the author of the paper presenting, because it means we can ask you even more insightful questions today. So thank you very much. If anybody's got any questions for Kathy, or even just any comments, do pop them in the Q&A or the chat box. But I think what was really interesting about that piece of work was that in the design of the guidelines, patients and representatives were involved from the very beginning. And I think in bariatric surgery, we've still got quite a long way to go with really embedding the patient voice in the research process. Have you got any advice for us as clinicians or as researchers about how we can get a bit better at kind of including that patient voice, and just a little bit about your experience of working with patients on a piece of research?
Yeah, it's great, I suppose, observations. So with the original Canadian guidelines, they had patient representatives on the governance groups, and they would have reviewed the guidelines, but they weren't involved in writing any of them. So we took maybe a little step forward with that, which we're very proud of as well. We have a very strong patient representative group in Ireland. So I think that was really helpful. So I would say working with existing groups where they are is good, because you tend to get wider representation within those groups. We try to certainly in ASOI, we've tried to embed patient representation within the group more broadly. So we've had a patient representative on our group for as long as I'm involved, probably 12 years. So I suppose we weren't coming asking for them to specifically get involved in this project. I suppose it's about embedding that and threading that throughout.
Yeah, excellent. And thank you for doing that and showing that it can be done, and it can be done really effectively.
Yeah.
We've got a comment from the audience here just saying how great it was that within the adaptation team there was such a wide representation of healthcare professionals, including physios, but I noticed there were psychiatrists and obs and gynae as well. So yeah, really impressive. We've got a question from the audience. So thinking about the public health input and some of the recommendations in the guidelines. So thinking about the context of the UK and NICE guidance that we use, did you do any economic modelling?
Great question. So we didn't, and it was definitely outside the scope of I suppose, the current project. However, in Ireland, our equivalent of NICE is called NCEC, and we are planning to undertake an NCEC adaptation of the adaptation, and they will require an economic analysis. So that is something we'll be looking at hopefully in the next year. There's real interest in that internationally. So again, it's something our Canadian colleagues through the project are very interested in maybe getting involved in and looking at something internationally, I think, with that.
Absolutely. And I think it's really interesting that you've drawn upon EOSS as well, because actually there's a lot of evidence to show that EOSS is actually more predictive of some of the outcomes after bariatric surgery as well, which would fit quite nicely into the cost effectiveness analysis as well.
Yeah. We were really conscious when we were writing the model of care. It was around the time that I suppose criticism of the tiered model had come out, just as we were publishing the model of care. So we were very conscious that we needed to move away from that idea of BMI. It's still involved in some of the tiering, but not in as, I suppose, kind of, it's looking at EOSS and that wider health.
Absolutely. I think one last question. There's a few more in the Q&A box. So after you finish, if you want to answer any of those live, that would be great. But really interested, is there any kind of review process built in to see how and if the guidelines are implemented?
Yeah, so we're planning some dissemination, I suppose, over the next couple of months. We'll be doing some training workshops at ECO if anybody is joining us in Dublin in May of next year. We'll be looking at some analytics, I suppose, in terms of downloading as well of the guidelines. So there are main plans at the moment for looking at that. Fabulous.
Thank you so much, Kathy. I will hand over to Roxana to introduce our next presenter of the next paper. Thanks, Kathy.
Thank you very much, Sally. Well, for our next presenter, we have Dr. Ahmed Al-Wasaibi, who's the Bariatric Fellow at St Vincent's in Dublin. Really excited, is going to talk about revisional Roux-en-Y gastric bypass versus OAGB post-sleeve. The floor is yours, Ahmed. Thank you.
Thank you, Roxana. Okay, can you hear me?
Yes, yes.
Thank you, Roxana. So my name is Ahmed. I'm currently a fellow in Vincent Hospital. I would like to thank BOMSS for giving me the chance to present today. Sorry. So I'm presenting today this article that was published in September 2022 in Obesity Surgery, which is the SVUH official journal. And the title is Revisional Roux-en-Y Gastric Bypass versus Revisional one-anastomosis gastric bypass after failed sleeve gastrectomy. And this is a randomized controlled trial. This study was conducted in Egypt, and it's good to this one of the senior author. He's actually an epidemiologist, and it's good to see this kind of collaboration between a surgeon and the epidemiologist in conducting this kind of study. So the background, so we know that sleeve gastrectomy was started as a part of BBD or duodenal switch, and Michel Guinier developed the two-stage approach. And in 2003, he published that a sleeve gastrectomy has been proven as a safe standalone procedure in patients with super obesity. And currently, a sleeve gastrectomy is considered probably the most common bariatric procedure performed all over the world. However, sleeve gastrectomy has been reported to be associated with moderate to high revisional rate, reaching between 2% to 33% in some study. And probably the most common reason for revisional surgery after a sleeve gastrectomy is weight regain, and followed by gastroesophageal reflux disease. And the question comes, what is the best surgical options after failed sleeve gastrectomy? We know that gastric bypass has been used as revision surgery following weight regain, recently introduced or over the last decades. The one-anastomosis gastric bypass has been shown that, for example, in the Omega trial in 2019, that it can probably give more weight loss over comparing to the Roux-en-Y gastric bypass. So the aim of this study was to compare the outcomes following a revisional gastric bypass versus one-anastomosis gastric bypass in patients who failed sleeve gastrectomy. And the primary outcome was to compare weight loss, complication rate, resolution of associated obesity complication, along with nutritional assessment with a 2 years follow-up. So the methodology of the study, this is a single-blinded randomized controlled trial. It's aimed to compare the Roux-en-Y versus one-anastomosis gastric bypass. It was conducted between 2018 and 2020 with a follow-up of 2 years. The study got an ethical approval from Alexandria University. It was conducted in 2 specialized bariatric centers, and it was conducted by 2 certified bariatric surgeons. And the study follows the CONSORT guideline for RCT. And in terms of inclusion criteria, they included patient age between 18 and 60 years. And according to this study, the weight regain was defined as any increase in weight above the lowest reported weight by the patient, and or BMI above 35. All patients had MDT assessment, including dietitian, nutritionist, physician, as well as surgeon. All patients underwent upper GI endoscopy along with ultrasound prior to surgery. They excluded any patient with grade B or higher reflux disease. As I mentioned, the study endpoint was weight loss, post-operative complication, nutritional assessment, along with improvement of obesity comorbidities. In terms of surgical technique, the good things about the study that they standardized the procedure. So all patients got a Clexane 12 hours before surgery, and blood thinner injection will continue for 21 days. In terms of gastric bypass, the pouch was created at 5 or 6 centimeters from the OG junction, and both elementary and pancreatobillary limb or BP limb were 100 centimeters. In terms of OAGB, started at the crow's foot on the lateral curvature. However, they haven't specified the length of gastric pouch with a 200 centimeter BB limb. And all patients had a multivitamin calcium iron tablet after procedure. In terms of statistics, they calculated the sample size based on assumption of a power of 80% along with alpha of 0.05, and they found that they needed at least 64 patients in per group, and they counted for loss of follow-up by increasing the sample size by 20%, and they needed at least 154 patients for this study. In terms of randomization, this was a single blinded study, and allocation was done when the patient was under general anesthesia. This is the concert flow chart, and you can see that they assessed 294 patients over this 2 years period, which is quite high for over 2 years. So they excluded patients above the age of 60, and they excluded all patients above the grade B or higher reflux disease. They ended up with 176 patients that were randomized, which is above the required sample size for their study. They ended up with 80 patients in each arm. When it comes to demographic data, the mean age was around 43, and the mean BMI before refrigerant surgery was 45, and almost all the demographic data between two groups were comparable. It's good to mention that all patients underwent endoscopy and sleep volumetry as well, and it's comparable as well between the two groups. There was a quite higher hiatus hernia rate in patients with Roux-en-Y gastric bypass, but it was not statistically significant. In terms of blood test, both were comparable between the two groups. In terms of perioperative details, as you would expect that Roux-en-Y gastric bypass required longer operative times because it includes two anastomoses along with the closure of the mesenteric defect. And patients who had one anastomosis gastric bypass, they didn't close the mesenteric defect. It's good to mention as well that concurrent hiatus hernia repair was performed almost 30% of the patient. It's good to mention that in terms of complication, they had quite low complication rate because this is revisional surgery. They had only one patient with gastrojejunal anastomotic leak in the Roux-en-Y gastric bypass group that was treated with a stent. In terms of bleeding, they had one patient in each group. When it comes to late complication, they had a patient, only one patient in the Roux-en-Y gastric bypass group who had internal hernia, who required intervention. When it comes to 2 years follow-up, post-operative labs and nutritional assessment were comparable between the two groups. They reported that there was statistical significant difference when it comes to HbA1c. However, it was lower in patients with one anastomosis gastric bypass. However, this was not really clinically relevant. When it comes to the trajectory of BMI, you can see that before sleeve gastrectomy, the two groups were almost similar with a BMI of 49, and the BMI went down to almost 30, and then they regained around 15 points in their BMI before undergoing a refrigerant surgery. And you can see from the charts that both groups had quite good results, and there was no statistical difference between the two groups. And it's good to mention that after both Roux-en-Y and one anastomosis gastric bypass, they had lost more weight than after the first procedure, which is sleeve gastrectomy. When they compare as well the excess BMI loss, and they found that at 6 months, patients who had one anastomosis gastric bypass had more weight loss at 6-month mark. However, at 2 years mark, there was no difference between the two arms. When it comes to obesity-related complications, that is dyslipidemia, diabetes, and hypertension, both group did respond to both surgery. There was a trend toward more resolution of the comorbidities in patients who underwent Roux-en-Y gastric bypass. However, this was not statistically significant. When it comes to discussion, we know that weight regain is probably the most common reason for revision after sleeve gastrectomy, as published in the recent systematic review. And the revision rate would increase from 10% to 20% over years. When it comes to what's the optimal revision surgery after sleeve gastrectomy, I think we still need more data in this regard. Roux-en-Y gastric bypass has been there for years, and we know that it has a good long-term data as a primary procedure with good outcomes for both weight regain and reflux disease. OAGB is a relatively newer procedure. However, it is, as you know, the simpler procedure. It includes only one joint. There's a very low risk of internal hernia. And it's good to mention that there is OAGB was recently acknowledged by the ACMBS. I think the other area of debate, what's the optimal length of the biliary limbs and the alimentary limbs in both Roux-en-Y versus OAGB. This RCT compared both OAGB to Roux-en-Y gastric bypass, and it showed that there is an equivalent BMI reduction after revision surgery. When it comes to complication, as I mentioned, it was comparable between the two groups. There was one leak in patients who had Roux-en-Y gastric bypass treated with stent. Almost all patients with symptomatic reflux disease had their symptoms relieved after a procedure. Bile reflux was reported in 2 patients with OAGB, which is probably the most concerning things in patient who was undergoing one anastomosis gastric bypass. When it comes to marginal ulcer, they reported 2.5% in patients who had Roux-en-Y gastric bypass. Associated comorbidities, it was comparable between both groups. When it comes to criticizing this paper, one of the strengths in this paper, it is an RCT, well-conducted RCTs, and it was conducted in a bariatric center with the support of full MDT. And the good thing is that they standardized the surgical technique between the two groups, and they have quite a good follow-up. When it comes to limitation, the power of this study was conducted to show a 10% difference between the two groups. However, this can miss a subtle difference between two groups. This study provides a short-term follow-up. I would like to see a long-term follow-up this study. Although they mentioned that one of their limitations is excluding patients with grade B reflux. I think I would be reluctant to do. I think it's probably most surgeons would not do one anastomosis gastric bypass in patients with a severe or grade B or higher reflux disease. One of the limitations is that although it's out of their hand during the COVID pandemic, most of the follow-up, more than 80% between the period of March 2020 and April 2021 were virtual appointments. This might affect the primary endpoint and the reliability of weight data. So in conclusion, both revisional one anastomosis and Roux-en-Y gastric bypass has comparable outcomes. They wrote that given the advantage of that one anastomosis gastric bypass is simpler, easier procedure, it might have a greater chance of being the optimal revisional procedure in the future. Thank you.
Thank you very much, Ahmed. That was a brilliant presentation and really comprehensive overview of the study. It's really good to see a new bariatric RCT, to be honest, and I think we should commend the authors on the model of the study. and certainly such good recruitment and retention numbers, because it can't be easy to recruit patients blinded to procedures. What are your thoughts on the technical aspects of the procedures that the authors mentioned? Because there was some, you mentioned in terms of the results, or in the papers, they've mentioned about operating time being significantly reduced with the OAGB, but also in terms of perhaps the morphology of the pouch and then the reconstruction. Do you have any thoughts in terms of what you think? I know overall complications we've seen are reduced, but from what the authors have said in terms of that aspect of it and patient selection.
Yeah, thank you, Rosanna. Well, I suppose one of the good things about this study is that they standardized their procedure. So they chose 100 centimeter for the biliary limb and the alimentary limb, although some of the critique that come to Omega trial that you cannot compare really 200 centimeter OAGB to 200 centimeter Roux-en-Y gastric bypass, because the biliary limb length is different here. But I think it is a reasonable technique and the design of study is really quite good, especially with standardization. I think they used gastrography routinely, which we don't usually do it like here in Ireland, and they put a drain as well routinely in all of their patients. But overall, I think it is the surgical technique is quite good. They reported that it is standardized as well.
Okay, and thank you. And just before we're waiting for questions from the audience, one of the things the authors had used in what did you think about their eligibility criteria? Because I think you mentioned that they use the weight regain definition as any weight above the nadir, but we know that after primary bariatric surgery, we expect a certain amount before then reaching the plateau. Was that taken into consideration in terms of the patients at what time point they were then recruited within their post-operative pathway to determine what was classified as weight regain?
Well, that's a good question. So according to the criteria they use in the article, any increase in weight from the lowest recorded weight, well, and they added that the BMI above 35 plus minus 35. And I know that there's no international agreement and what's the definition about weight regain. In general, we probably accept the curve usually after sleeve it goes down, and then they regain probably 2 or 3% of their weight, and then it should go around a steady. So yeah, you're right. I think they should define more what is weight regain. However, according to them, like the mean BMI prior to a revision surgery was 45, which is quite justified to do a revision surgery. So most of their patients, they regain at least 15 points of their BMI after a sleeve gastrectomy. Yeah.
I think that brings us really nicely onto a point that I think one of our colleagues are going to mention now, in terms of how do we define success after the primary surgery, and the opposite, the word kind of what is deemed lack of success. Sheriff, did you want to raise a point about the definition of what we're saying in terms of failure?
Yeah, I was just going to ask you, what do you think of the title of the paper?
Oh, that is quite good. This is it's clearly defined what is the purpose of the study.
Yeah. So I mean, the one thing that we've all picked up on, which hopefully we'll try to avoid, and when we're writing our own papers, is use of the word failed. So failed sleeve gastrectomy. It's quite stigmatizing. It's a stigmatizing term when used in terms of either a surgical procedure or a patient has failed in their weight loss surgery, etc. So ideally not to use that term really in the modern day journals, and they have some quite rigorous and clear terminology that should be used and terminology that should be avoided. So I think that's definitely one thing that I would suggest could be improved. It was good to see actually in this RCT, which was very well designed, very well run, very well conducted, good retention, as you mentioned, and good reporting of the intention to treat outcomes, that they did have MDT assessment before taking the patients on. for the revision. Two things I couldn't understand is why they excluded grade B GORD. Did the authors mention in the paper why that was an exclusion criteria? Because by definition, if you've got severe, grade B, grade C esophagitis after a sleeve, you'd want to convert them to a gastric bypass. Did they say why?
No, actually, it wasn't mentioned why. So just
Okay.
exclusion criteria.
Just a standard exclusion criteria. And I guess the other thing that
the aim is to direct the study for weight regain and not to focus on
yeah. Okay, fair enough. And just the other thing I noticed, 10% smokers in both groups in patients who are having a gastric bypass. I mean, my practice for a number of years now has been to not offer the bypass to smokers, even if they give up, because 50% of them will go back to smoking again in the first year after surgery. And, needless to say, they had a 2.5% marginal ulcer rate in their Roux-en-Y gastric bypass. So that was something else that sort of stood out. But I thought otherwise, interesting paper, good results. Run from 2018 to 2020, and they used a 2-meter length for their OAGB. Do you have any views on that, on using a 2-meter length?
So as far as I know, that there's no standardization in what length should be used. When you're using a longer OAGB or BBD limb, will compensate. You will probably lose more weight, but on the other hand, you have more nutritional deficiencies. And here in Ireland, like we do 150 centimeter OAGB. We don't aim for 200 meter, just because of the additional nutritional deficiency that can happen with the longer limb. Some author I know, they have suggested that to tailor the BB limb according to the BMI. But there's no standardization in this regard.
Fantastic.
Very helpfully, we actually have one of the authors of the paper in the audience who's commented to answer your question, Sharif, and has said that OAGB and obviously gastroesophageal reflux SAGE are not ideal with controversial results, and therefore they've excluded that.
I thought so. No, I thought that might be the case, but it was worth raising. So always lovely to have the authors join in to hear us critique their papers. So I hope we weren't too harsh. It was a really, really enjoyable paper. So in the interest of time, because we've just gone 3 minutes over, can I close? Is there any other comments that anybody else wants to add? Sally, Roxana, Helen, Naomi, Kathy or Ahmed?
No, just to thank you again for the opportunity. We're all really grateful to BOMSS for inviting us to present, and hopefully it'll be the first of a number of presentations from Ireland.
I hope so too. And lovely to have your unit come on and show the fantastic work that you've done. And Kathy, many congratulations. Ahmed, thank you very much for a lovely Journal Club presentation. Sally, Roxana, thank you for co-chairing. And thank you all tonight for joining. We'll see you all on the 23rd of November for the next webinar. Good night.
Good night.
Bye.
Thanks.